first time in beautiful Trivandrum, so been to Kerala twice, but not to the capital. And yeah, so let's kick off with how to understand CGM to really make it easy to work with CGM. Here are my disclosures. And as we talk about CGM, we first need to understand what types of CGM we have. The majority of us are using unblinded CGMs. When people with diabetes have direct access to their data, it gives you direct display of the glucose value, of the trends, and also gives you alarms if needed. We will talk about alarms also in a little bit. On the other hand side, and that's maybe not the most common one used, we have blinded CGM. Blinded CGM we might need if we do not want to have any interference from the person reading the glucose data, but us having access to 24/7 glucose traces. That could be important, for example, if you want to monitor lifestyle changes without CGM interfering, or oral agents where we want to assess their true effect without having any activity taken by the person living with diabetes because they have access to their glucose data. Usually most of the systems can be worn between 10 and 14 days. Now we have plus versions of some of the sensors that gives you an extra gratitude day. When we then think of continuous glucose monitoring, how is that set up? And that's a very nice depiction from the Cleveland clinic that is slightly adjusted because where I have put the reader, they have put a pump, which is then not, of course, the only device, and so I wanted to be a bit more open on that. So you have the sensor being implanted in the subcutaneous tissue. Do I have any pointer that's working? No. We have the reader that is then connecting with the sensor and displaying the data to you. And if persons are using that routinely, some of the smartwatches and smartphones can also indicate the glucose value. In contrast, what we have when we look into capillary glucose monitoring, we now have a broader abundance of data. So we do have the trend arrows as well that tell us about the direction. That tell us about the direction of the trend, where the glucose is going to be in the next 15 minutes or so. We also have the information if the signal was lost, if this is needed. We then have the area where glucose should be, the target range. And what we also need to keep in mind whenever we talk about glucose and the persons are reporting that their glucose values they measure with the sensor do not really meet the glucose values that they measure with their glucose meter. That is because we do have a time shift between the two, so we do have a delay because of course the blood needs to circulate, we need to have the glucose going to subcutaneous tissue, and that leads to some delay. So when people feel, for example, symptoms of hypoglycemia, they should trust the symptoms, especially if the arrow is trending down, rather than waiting until the glucose value actually goes down. And that's a very nice presentation from Dr. Miller, where he just tells us how much we can expect in terms of changes when we have 1, 2, or a steep arrow or pointing up or downwards. And whenever you talk to people with diabetes about glucose and their trend arrows, so they should really treat that kind of signal different from a capillary glucose value, because we need to take the rate of change into account. So where is my glucose going to be in the next 15 minutes or so? And that helps people then already taking their treatment decisions. If they're maybe not that good in calculating, they can, for example, if the arrow is pointing up or straight up, add 10 or 20% of the planned insulin dose, saying they can reduce 10 or 20% in case of downwards pointing on arrows. And a new concept that may be around now also in India in the coming time, as far as I understood, is that we also have glucose prediction as a very new format that is not only 15 minutes, but really gives you a 2-hour prediction and also gives you nighttime prediction. So that's two new terms that you need to add to your glucose vocabulary. And also when you talk to people with diabetes, they might need to understand how to adjust to those new alarms and alerts. And how that can look like. So these alerts could tell you, for example, as a visualization, and that's like the weather forecast. So of course it's not 100% sure what's going to happen, because of course you can interfere, you can adjust, but it gives you an expected frame of what can happen in the next 2 hours or even overnight if you do not interfere. And the further in the distance, the further down you see, the broader the curve becomes, just because we are not really able to predict the future 100%, but at least it gives us a tendency. And whenever people will get in the future a night low predict alert, they can adjust the insulin dose so that they feel safe and can go to bed without being awoken by their glucose sensor. And I'll just fill that slide quickly, not to do it in a one-by-one manner, just to highlight again what we should target at. We want to have a target range of 70 to 180 milligrams per deciliter in more than 70% for the majority of our people. And if we can manage, of course, and having no hypoglycemia on the other hand side, we would not be reluctant in having 100% in the green range, because that is where more or less the glucose of people without diabetes is located. On the other hand side, when we factor hypoglycemia, adjust euglycemia, hyperglycemia will also go down. In older and frail people at risk of hypoglycemia, we are not as stringent, so we have the same target range, but we are happy if we achieve that only 50% of time with the lowest risk of hypoglycemia. In contrast, pregnancy, both type 1, type 2, and GBM, we have a lower target range, where for the regular diabetes care we would already consider that as hypoglycemia, but here we say that's the normal range. And also if you have ever worn a sensor, probably you will have seen that your glucose was also in the maybe even 50s, maybe hadn't eaten for a while, or maybe because the sensor sometimes is of course also under review. So in pregnancy, hyperglycemia starts at 140, hypoglycemia at 63, and again we aim to increase the target rate, the target range. We're going to talk about pregnancy a little bit tomorrow as well. When you then look into our sensor data, and you will get very nice reports that you can have a look at. And I want to familiarize you also for the last part of this session about the HB, because probably you're going to see a lot of reports to be interpreted. And this ambulatory glucose profile, it overlays the data from 14 days and gives you a nominal rate. And out of that, we can have a look what the timing range in these 14 days is. Again, we have the same target range, and it also tells the person how many hours per day that would be in the target range. And importantly, 5% increase in the target are associated with relevant clinical outcome, reduced microvascular complications. So whatever you can achieve in 5% more is worth going for it, because on the long run it will help our people living with diabetes. When we then look a bit more into that HB report, and we have different display modes. So we have the immediate curve here that gives you on average where the glucose lies in the 14 days. I will also talk a little bit later about the blue and the light blue range. Importantly, you also have daily views that gives you an indication of what happens on individual days. So for example, if you have always a pattern of hypoglycemia at night, you will see that in the overlay curves, and you will see that in the detailed curve, where you can look if that is maybe something that happens specifically on weekends or on weekdays. If you exercise more on these days, all of that can help us to better understand our data. And why is continuous glucose monitoring so important? So we do have, of course, very long-standing experience in using HbA1c as our prime marker, but it may be a bit frustrating for some people if they do not really have kind of information about rapid changes. So they do their best and still HbA1c is high. So if you then use timing range and the glucose trace gives you really quick feedback, compares any time periods that you want to see, also shows you about hypoglycemia, and is less prone to interference. So for example, if you have any kidney disease, you might be a slow metabolizer, and that might drive your HbA1c up, and the continuous glucose trace might be more suitable. When we then look into clinical trials, also clinical trials, continuous glucose monitoring is more and more used, and we use more or less the same metrics. I'm not going to talk all through those metrics here that you have depicted. You can take the paper from Professor Bartolino and have a look yourselves, but I want to mention one word, and that is, in my opinion, the most important one that will come across you in the next couple of months and years, and that is timing normal glycemia. Especially for people who are on AIP systems and also on oral agents, we will strive for more stringent control, which will be in the range of 63 to 140 milligrams per deciliter potentially, or at least 70 to 140 milligrams per deciliter. So the jury is still out for 63, so there were wild discussions last time in Amsterdam discussing about it. And I promised you to talk a bit about that ambulatory glucose profile. So in the past, before we had the standardized metrics, we had very difficult to interpret spaghetti curves over time in different colors, and you could not make an easy representation out of that. And when putting these data together, you have again the underlying individual parameters, but you have the median curve, which tells you on average where the glucose is. You have the blue curves, which tell us about 25 and 75% of the glucose values, and the light blue curves, which tell you about 10 and 90% of glucose data where they are located. And why are also the 25 and 75% important? Because that's a relevant amount of time that people spend there, and potentially, if the glucose is high around the afternoon following meals, there might be some adjustments that are needed around lunch, for example. On the other hand side, the 10 and 90% of course are not that important. They might be interesting for you to better understand what has happened. Maybe there was a pizza meal, a very high-fat diet meal, a meal that you did not expect having so many carbs, but that's not the routine that is happening. So another important parameter I just shortly want to touch upon is the glucose management indicator. You will also receive that value displayed on your readings, and that tells you a similar value as the HbA1c, but not completely the same, because there might be diseases affecting glucose metabolism with the erythrocytes. So the glucose management indicator is really focusing on the CGM data. And as a last part of the lecture, just really keep it simple, make the three-step analysis, look if the targets are met, look if you have too much hypoglycemia, try to see what is the main problem, and explain that to your person living with diabetes. Just shortly also mention we need glucose metrics being displayed on platforms, because otherwise it's really difficult if you don't have access. So be sure that whatever you prescribe you have access to, may that be one or the other provider. And as a take-home message, we have now very powerful tools that help us to better understand glycemia. We can better assess glucose traces over 24 hours, but we should really report it in a standardized manner, so if a person transfers maybe from Mumbai to Delhi to the Kochi, they can go with their patient letter and everyone has the same language.
One or type 2. So maybe SGLT2 could help you to get that down. Did you try?
Pardon?
With an SGLT2 inhibitor, did you try?
He's on metformin, BP4, SGLT2.
SGLT2 is also
Yes.
there. Then
So she asked if you want to ignore it.
The thing is, our meal is carb loaded.
Yeah.
You can keep educating, but nothing much changes. These are the idlis and dosa. They don't eat much. They have maybe only 2 dosa, sambar, that kind of a breakfast, which is not going to change.
I mean,
But
they,
before commenting on the entire thing, is it type 2 young, old?
Type 2, 40s, 6 years of diabetes, on metformin, TTP for
No other comorbidities?
No other comorbidities, no other comorbidities.
Physically active?
Physically active, working.
I mean, probably you can ignore it because it's a very short time, but if you can manage it would be better. Have you ever tried, and that's what I tried with my dad, and we were discussing yesterday about eminence-based medicine. Yeah. No, but something even easier. Did you ever try that the person drinks a glass of cold water with vinegar and see what happens with the carbs? So I do that with my dad now, and his glucose is quite good. Yeah?
Apple cider
Yeah.
with
Apple cider. Before me.
Before me.
yeah, just before.
So you can add 5 minutes. Otherwise, you can add 5 minutes in the morning. 5 minutes of cooking. Rather than before, you can see the DPO2, the 5 minutes and 15 milligram. So that postprandial excursion will be minimal.
Okay. Now,
Maybe
audience.
you give us an update in half a year what happens. I would also be